Okay. So we're going to start our session on developing trauma-informed care for unhoused populations. So we're going to start with Dr. Simon Hatcher. Dr. Hatcher is a psychiatrist with Ottawa Inner City Health and the Ottawa Hospital. He is also a full professor at the University of Ottawa. He runs the Hatching Ideas Lab, which focuses on answering questions about the best way to care for people with mental health problems from underserved populations. In the lab, there's a focus on trauma, suicide prevention, and COVID-19. He is originally from Devon, England, and after training in psychiatry in the UK, moved to Auckland, New Zealand, where he worked for nearly 20 years before moving to Canada in 2012. He lives on the Quebec side with his motorbike, parrot, dogs, and horses. Please welcome Simon.
Thank you. Kia ora. Bonjour tout le monde. So I thought I'd ask a basic question. What is trauma-informed care? Because we all talk about it, but I don't know if we actually know what it is. And this is going to be a short, brief presentation, which just really raises questions. So I'm going to just let you know how currently trauma is defined, go through how people think about trauma-informed care and why it's necessary to think about trauma in the population that we serve, even though that may seem, you don't need to say that, but I'm going to say it anyway. And then I'm going to talk a little bit about one of the research projects we're doing in our lab, and I'm going to end with a request to participants. So that's what I'm going to do. So what is trauma? I mean, the answer to this is in many ways very straightforward. You just look it up. So if you look in DSM-5, it says it's an event that involves death or threatened death, or actual or threatened serious injury, or actual or threatened sexual violence. And the picture is there because when trauma entered the psychiatric and modern language, came, of course, with the Vietnam vets in the 60s and 70s. And this is what they meant by trauma, is when you are threatened with death. So it's not necessarily expected difficult times in life, like having an unwell partner or an unwell parent. It's when death is present or threatened, or there's actual or threatened serious injury, or actual or threatened sexual violence. Of course, DSM-5 then expanded this to mean so that it didn't need to be direct, but it doesn't have to be. And it could also occur indirectly. So I think one of the things which isn't picked out enough when people talk about trauma is the different how you witness the trauma, whether it's directed at you or whether you're a witness. And we work a lot with first responders as well. Like we do research on both sides of the street. And with first responders, of course, they're often not the recipients of violence or threatened death, usually. They're witnesses. And I think that probably has a different effect on you than being the recipient of it. It's one of those things which isn't maybe teased out enough in the trauma literature. And also, of course, how different traumas affect you, I think, is, again, one of those areas which hasn't been teased out enough. So abuse versus neglect. Neglect probably has a different effect on you than abuse. And again, the literature is fairly silent on this. It's one of those things, again, which needs to be, I think, teased out a bit. ICD-11, which is actually the worldwide classification, not as opposed to DSM-5, which is mainly North America, they define trauma as an event or a series of events of an extremely threatening or horrific nature. And one of the criticisms of the whole trauma world is that sometimes trauma is used to refer to anything bad that's happened to anybody. So what I'm trying to do here is just maybe reclaim the one end of the spectrum is what trauma means. So what is trauma? Trauma and homelessness. So I mean, this is stating the obvious. Experience of trauma is very common in people who are homeless. When people have tried to look at this, nearly everybody has an experience of trauma. And of course, living on the streets, not having a home, can lead to further trauma, gets into this vicious cycle. And at least half, maybe more, of people who are vulnerably housed have complex PTSD, compared to about 3 to 4% of the population. So it's massively increased in the people that we try and serve, that we're talking about in this conference. What is complex post-traumatic stress disorder? Of course, this isn't in DSM-5, but it is in ICD-11, which is the World Health Organization's classificatory system for all disorders, not just mental health. So complex PTSD is where you're exposed to a traumatic event or events which have been sustained or multiple. So sexual abuse, physical abuse, and so on. And there's 2 other bits to it. So it's defined by exposure. So you have to be exposed to something bad happening to you. And the exposure to those traumatic events, essentially, you can't escape them. So it's often stuff that happens in childhood. And you get PTSD symptoms. So you've got all the usual PTSD stuff. So it's re-experiencing traumatic events, nightmares, flashbacks, etc. Avoidance of reminders of bad stuff that's happened. And this heightened sense of vigilance, which is what you see a lot of the time, is people's alarms are just going off all the time and they never go off. And then in addition to that, you get the disturbance of emotional regulation, negative self-talk. People often left with a incredibly negative way of thinking about themselves, which can come as a complete surprise to me as a clinician when I'm seeing them, that their assumptions about themselves are so different to me. And that's one of the things about trauma-informed care, is being aware of that. And difficulties in forming and maintaining relationships, because of course, if one of the things you learn, of course, if you've been abused as a kid, is that people who try and take care of you will hurt you. So me coming along as a doctor and saying, I'd like to take care of you, can often seem quite threatening to people. And that dynamic plays out time and time again, often in people who I see, especially for the first time, which is why seeing it, working with peer support workers and others with the peer skills they have is often very useful to try and negotiate that relationship. So that's complex PTSD. The way they tried to get around it in DSM-5 is they thought about doing this, but then they decided no, so they just expanded the criteria for PTSD a bit in the last DSM-5. It doesn't really matter except to psychiatrists, so I'm not going to bore you with that. So trauma and trauma-informed care. So, I've defined trauma. I've told you that it's common in people who are vulnerably housed, and often causes complex PTSD. So what do you do about it? So people talk about trauma-informed care. So is this just a philosophical and cultural stance? Is it something that you think? Or is it something that you do? And is what I consider trauma-informed care, what people who are vulnerably housed, people I work with, people I try and provide some care for, do they experience it the same way? Do they think what I call trauma-informed care is actually trauma-informed care? So if you look up trauma-informed care, you get overwhelmed with models. So you have the 4 R's of trauma-informed care, which here is realize, recognize, respond, and resist re-traumatization. And so realizing is something like you realize, so it's a thinking thing, okay? And then you recognize the signs and symptoms of trauma in clients and families. And again, that's a thinking thing. How would you know, how would I know from looking at somebody whether they are recognizing or realizing? And then responding by fully integrating knowledge about trauma into policies, procedures, and practice. Useful for organizations. What about clinicians like me on the streets? Yeah. And resist re-traumatization. So that's something that's in our minds a lot, all the time. especially with somebody like me who has the power to coerce people into care. Does that do more harm than good? So maybe we could operationalize that. But the point is, there's a lot of thinking in that model, not a lot of doing. Okay. And then we've got a 4R model, and we've got 6 guiding principles to trauma-informed care. So safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, cultural, historical and gender issues. All important, but how do you actually do it? What behavior, what words do I use to actually put that into practice? So lots of principles here. Or we've had 4 models, we've had 6-factor models. Now we've got 10 key ingredients here. Or we've got 5 key ingredients. So 10 key ingredients are lead and communicate, engage patients in planning, train all staff in what? Create a safe environment to prevent secondary trauma, and so on and so forth. You can read through it. It does actually have one behavior there, which is screening for trauma and training all staff. Build an informed workplace. Interesting, it says hiring. One of the things that's really come home to me recently, I can talk about it a bit later, is the importance of trauma-informed care going through the whole organization, not just in frontline care, but HR departments, hiring, the whole process. It needs to go through the whole organization. That's a slightly different talk. So there's 10 key ingredients, 6 key ingredients. We've got safety again, choice, collaboration, trustworthiness, and empowerment. So the point I'm making is, one of the things this tells you, if there's all these different models, nice pictures, it means nobody's actually quite worked how you do it yet. The most comprehensive review that I know of is by Hopper in 2010, who looked at trauma-informed care and homelessness services and did a review of the literature and tried to tease out, well, actually it's a narrative review, it wasn't a systematic review, it's a narrative review. Actually tried to work out what trauma-informed care actually looked like in homelessness services. And she found 4 things. One is trauma awareness. It's again the thinking thing. Safety comes up a lot. Choice and empowerment, and strength-based. The strength-based stuff I find really hard, actually, because as a doctor, what you get used to doing is you ask people what's wrong with them and what symptoms they have. It doesn't come naturally to me to ask people about their strengths. But it's often a very useful conversation to have. We've addressed this in 2 different ways. One way we've done it is we did a systematic review of interventions to treat PTSD and also by implication complex PTSD in people who are vulnerably housed, which are described as trauma-informed care. And we wanted to see how people describe this. How did they put it in? How do they put trauma-informed care into practice? And scraping through the worldwide literature, and this was published last year, basically there were 3 things that people said. One is about the importance of physical and emotional safety. The second is about the experience of feeling heard, which you know it when you see it, which is quite hard to operationalize. And giving people who are often voiceless the gift of being heard is actually really important. And being flexible with choice and being available when people are ready. If you actually look in the literature, that's what they say. And being available when people are ready is not necessarily something which actually was in any of those models when they talked about trauma-informed care. And how do you operationalize physical and emotional safety and choice? One of the ways I do it is always asking people how they want to set up talking to me. Do they prefer to go for a walk? Do they want a snack? Giving people choice of snacks. Door open, door closed, what do they want to sit on, and so on and so forth. But those sort of things aren't really covered when you talk about trauma-informed care. And of course, there are lots of barriers to doing trauma-informed care, one of which is no safe spaces to do this. Substance use sometimes makes it hard to deliver trauma-informed care, according to the literature. And there's barriers to follow-up, barriers to to creating and maintaining a relationship. It's one of the things I really admire about the nurses who I work with, is their ability to create relationships over time with people on the streets, which is admirable. And I'd love to know how they do that. So could you write it down, please, so other people can do it as well? And of course, high staff turnover, which goes back to the first session this morning. So, my conclusion from looking at the various theoretical models about trauma-informed care and having had a look through the literature about trauma-informed care in people who are homelessness is that there's four questions here. One is how to operationalize trauma-informed care for clinicians. What do I do? Which makes it, how can you tell I was doing trauma-informed care as opposed to somebody else not doing trauma-informed care? What would it look like? If you had a video of me doing trauma-informed care, how would it differ from anybody else talking to somebody? And what is trauma-informed care for people with lived experience? And does that differ from what I think is trauma-informed care? How can we manage the effects of trauma on clinicians and other carers? Again, that goes back to the first thing this morning. We're doing a project on that with first responders, and an obvious place to go next with that would be in peer support workers and staff working in frontline work. And what's the best way to manage the effects of trauma on vulnerably housed people? I mean, recovery from the damage that trauma does is a journey. It's not necessarily an end state, but how do you progress along that journey? How can we help people progress along that journey? So those are some of the, well, those are the four research questions we're trying to address in our research lab.
Thank you very much. I'll be presenting results from two projects I've done in Simon's lab. I work with Simon. He briefly touched on one, so we might kind of breeze through some of that. But yeah, quickly, like Kim mentioned, I'm at Western Ontario. I do qualitative work there. So I'm in the shelters doing interviews about service restrictions and how that impacts. Is it not on? Okay, I'll talk closer. How service restrictions negatively impact service users and how it also has an effect on service providers. And then my work, my thesis is stigma related for substance use among homelessness and how we can destigmatize social and health settings. But today I will be talking about narrative exposure therapy and a study we did with that. So I'll quickly go over this. I know we've heard a lot about, oh, yeah, sorry, I can't see what I'm doing. There I am. We've heard a lot about the numbers in terms of homelessness, but on any given night, 25,000 to 30,000 people in Canada are unhoused living in the streets. So we know that it's a problem. And like Simon mentioned, okay, complex PTSD is more common for individuals experiencing homelessness, and individuals who are unhoused have PTSD rates more than double that of the general population. So it's definitely an issue. Sorry, I'm having an issue up here. Okay, so one treatment option for PTSD is narrative exposure therapy, which is a brief trauma-focused psychotherapy that attempts to place trauma within a person's life. So this photo here kind of represents what NET is, where the flowers represent a positive event in a person's life, the rocks represent a negative event, and you can kind of map out your life on this kind of timeline. During NET, participants construct detailed accounts of their biography with their therapist, and then in consequent sessions, they detail it more and more, so on and so forth. This can really help give meaning to an individual's life and the problems that they've faced, and it can help them develop a core sense of belonging and identity. So I didn't personally work on this trial, but they did this trial in the lab, feasibility and acceptability of narrative exposure therapy, which was pilot RCT. This is a really complicated way of saying essentially it only happened at our site, so it was a single site trial, open label, meaning the people delivering the care and those receiving it knew what group they were enrolled in, and they were enrolled in two groups, so either NET alone and then NET and genealogy, which we'll get into in a second. So I've kind of briefly mentioned what NET is, and then the genealogy piece. So previous experience of using NET in Maori in New Zealand, where it was used for people who experienced complex trauma. And it found that the people reported feeling valuable, being able to trace back their connections to family members that weren't in their direct circle of care, because sometimes people, like in their close circle, you can have damaged or dysfunctional relationships. So being able to trace it further back in your lineage can give you a sense of identity. And the metaphor that they used was that it can deepen a person's roots so that they aren't blown over by life's storms. So these included participants. They were individuals who had PTSD diagnosed or suspected and were experiencing homelessness or were vulnerably housed at the time of the study. Inclusion criteria was adults 18 plus referred from inner city or the psychiatric outreach program at the Royal. And they met DCM-5 criteria for current PTSD. And they were also currently unhoused or vulnerably housed. And the primary outcome of the study was to see if delivering NET and conducting RT was feasible and acceptable. So the primary measure of feasibility was recruiting the planned sample size over 6 months, including potential participants identified and the number of people consented. And then to determine acceptability for the population, we define this as at least 50% of those approached agreeing to partake in the study. Lastly, we wanted to see if it was feasible to collect outcome data in this population, which we described as loss to follow-ups being capped at 25%. And then a secondary outcome was to see if NET treatment in this population results in better health outcomes, including decreased severity of PTSD symptoms, changes in housing status, and overall health, quality of life, and substance use. So the demographics of the population, it was a smaller group, 2/3 men, 1/3 women. Generally, the age was about 40 years old. In future work, we would try and be more inclusive of marginalized groups and gender nonconforming folks. Nobody identified as gender nonconforming in this particular cohort. The lifetime prevalent substance use of individuals included was 11 of the 13 included, so 84%. And that didn't change over the life course of the project. These were the results. So of participants referred, 22 were referred to us, 1 was excluded based on PI recommendation. We can go through all this thing here, but essentially 14 were randomized to the trial, 7 in the NET, and then 7 in the NET plus genealogy group. 5 participants were referred to us in March 2020 after the COVID-19 pandemic kind of started up. So we were unable to find a safe place to meet them, and unfortunately we were unable to see them. So in terms of the feasibility, we were unable to recruit the desired sample size, unfortunately, within the 6-month goal. Total of 15 participants were enrolled over about 9 months. And the main reason for this was lack of trained therapists. There was a shortage, so we put recruitment on pause a number of times because a therapist would reach their caseload and they weren't able to see anyone else. Retention threshold of 75% at 12 weeks was not met, though 8 of 13 of participants completed at least 1 follow-up session, and of the 10 who participated, 7 completed the whole study. Of the 10 participants who started therapy, 8 completed 6 sessions, which is all of them, and all participants who completed the genealogy piece agreed to do that, to map their family history. All of the participants experienced multiple traumatic events in their lifetime, with childhood trauma being common, and PTSD scores decreased in both groups over the course of the study. A lifetime history of substance use was common in both groups, and substance use appeared to have no relationship with whether they completed the study or not. So in terms of the housing, 7 of the individuals partaking in the study were living in shelter at the time, the start of the study, and then 2 in transitional housing. 1 was living with a friend and 1 was paying for a living space. Many participants' housing types changed over the study, so they were constantly changing essentially. And those who did not complete the study were primarily living in the shelters, but mostly sleeping rough, so sleeping in the streets. And we did attempt to do a qualitative evaluation. So we were able to do that with the service providers, but unfortunately, again, due to the lockdown, we weren't able to do the qualitative interviews with the individuals with lived experience, because it was, again, at the beginning of the pandemic and there was no safe place to meet them. But of the qualitative interviews with the service providers, they unanimously expressed the need for services within the community. They were fully supportive of a larger scale trial, and despite staffing constraints, which was a major limitation in this study, the service providers indicated their willingness to navigate barriers to be able to help those who need the therapy in various settings in the community. So the major limitations of the study was, like I mentioned, lack of individuals trained in NET and just therapists in general, their availability, they're spread pretty thin. And then the study was underpowered to detect any significant differences. With respect to the genealogy report, if we were to do this again, we would have the report done before participants were seen by the therapist because it took several weeks to get the results back. And there's just a significant gap in trauma treatment for the unhoused community, which is a limitation in several studies related to this topic. I did not communicate with Simon before this presentation, so he's already kind of gone over the scoping review. I have a couple of visuals, but we can breeze through the methodology. We searched several databases with terms related to the topic that we were looking for. So we included a wide variety of studies. And then 2 independent screeners did title and abstract and then full text review. And we abstracted study characteristics, design, population, details about the informed approaches that were taken and key findings, which I'll show in a sec. We can again breeze through this, but essentially we started with about 2,500 articles identified through the databases, one through a Greylit search. Duplicates were removed, and then we full text screened 154 articles, and of those, 28 were relevant to our inclusion criteria. Simon presented this, but this is just a visual way to look at kind of how the studies found were mapped with the principles of trauma-informed care. So 4 studies were trauma-focused therapies, which were of lower quality, 3 single case studies for pharmacotherapy, 3 lower quality housing intervention studies, and then there were some non-trauma focused therapies, 16 studies with 5 RCTs and limited effect. Of the 10 studies that describe the trauma-informed care, mostly in the elements of physical safety, emotional safety, the experience of feeling heard and understood, and flexibility of choice as important. The literature also commented on the difficulty of providing care, including lack of private space to deliver care, the co-occurrence of substance use, and barriers to follow-up, including limited length of stay in different shelters, as well as staff turnover. So how can we move forward in the research realm? Despite the high prevalence of PTSD for individuals experiencing housing vulnerability, there is little evidence of what treatment is effective. Guidelines of treatment for PTSD recommend trauma-focused therapies as the most effective intervention. And this review clearly identifies that there's a gap in the research about how we can implement trauma-focused therapies in this population. Research needs to clarify which components of trauma-informed care are most important and how we can operationalize this, so how we can actually make it happen. And trauma-focused treatment should be accessible to people who are experiencing homelessness or individuals who are vulnerably housed. So again, going to them instead of making them come to us. And the delivery of effective interventions should focus on trauma-informed approaches with an emphasis on safety, choice, awareness, and how trauma affects acceptability and care with a strength-based approach. And that's it. Thank you very much.
Thank you so much, Brooklyn. And now we're going to have Liz Frye. Dr. Liz Frye has been a street psychiatrist for the past 13 years. She's the vice chair for the Street Medicine Institute Board of Directors and has led the Institute's annual International Street Medicine Symposia for the past 6 years. She works for Allegheny Health Network Center for Inclusion Health on their street medicine team in Pittsburgh, Pennsylvania, US. She previously founded a street medicine team at an Atlanta, Georgia Healthcare for the Homeless organization and was the director there for 5 years. Dr. Frye completed medical school at the University of North Carolina, Chapel Hill, and her residency, community psychiatry fellowship, and master's in public health at Emory University. Welcome, Liz.
Hopefully my slides will come up shortly. As we're waiting for that, I have maybe a couple of disclosures. One is I have long COVID and some amount of brain fog. So if I suddenly forget a word or just what I'm saying in general, there will be some audience participation for you to help me find that word. The other thing is I'm currently on medical leave for long COVID, but also for some traumatic experiences from work that had nothing to do with my patients, but the way that I was treated at my job. So I'm a little raw this morning. Okay. Well, you know what I'm going to do is I have my computer and I'm going to go ahead and get started. And when we have some visuals for you all, we'll just move on from there. So apologies to the visual learners in the room and congrats to the auditory learners. Okay. So the title of my presentation is Building Trust in Impossible Places, Insights from a Qualitative Street Medicine Study. I wanted to talk a little bit about what research exists out there already. Really what we were trying to understand is what does trust mean in a rough sleeping population? And how can a street medicine or street psychiatry team or healthcare providers in general gain the trust of people experiencing particularly unsheltered homelessness with whom they work? So what we know from the literature, by the way, there is no research done specifically on this currently, as far as I know, unless Simon has done it and I don't know about it. But what we can look at is that there's actually a lot of literature out there about how people experiencing unsheltered homelessness feel about their outreach workers. And there is rampant mistrust among those of people sleeping outside towards their outreach workers. And it leads to service refusal, including medical care and housing. We also know that stereotypes of people experiencing homelessness and past experiences of discrimination increase the risk that a person will feel unwelcome at a healthcare encounter. And unwelcomeness, if that's a word, that is not my slide set, unwelcomeness results in discontinuation of treatment or disengagement. And that mistrust plays a role in reluctance overall to seek healthcare and social services. So my qualitative study design, and I worked with a master's in public health student as part of her summer work between her first and second year to conduct this research. We had 26 participants. It was a convenience sample of people sleeping on the street. The only criteria was that they had to be sleeping outside and that they had to have at least one encounter with the street medicine team in some way. And so that could have been with our social worker or one of our nurses, the family nurse practitioner who provided primary care, or one of the psychiatrists on our team. The master's in public health student rode along with the team in the van to go to various encampments and did semi-structured interviews with people who were willing to participate. And there were some people who had an interaction with the street medicine team for the first time, and then she interviewed them right afterwards. And there were other people who had seen the team multiple times. She did the recruitment and the semi-structured interview out on the street during street medicine rounds on 10 occasions in 2018. And she performed the interviews. And she was previously unaffiliated with the street medicine team. Participants were majority male. Hey, look at that. So 88% were male. The majority were African-American or Black, and the majority were unhoused, as in sleeping outside, which was 87%. And then we also had transitioned some people into temporary and permanent housing. And we had the ability to continue to see some of them where they were living. And so 3 of the three of the people who we saw was technically not street rounds, but home visits. Okay, and so what our study found was pretty similar to what other studies have found, that there was a high level of stigma experienced by participants. And it negatively impacted their relationships with healthcare workers and with outreach workers, people providing social services. And further, in every encounter, our participants expected to be stigmatized, treated poorly, and discriminated against. And I think that's maybe one of the key factors that distinguishes the people the participants in the study compared to the rest of the population, perhaps. And we didn't look at like, what does everybody else in Atlanta, Georgia feel about their healthcare or expect out of their healthcare. But I would venture to say that maybe most of us in this room expect to be treated well and expect not to be stigmatized or discriminated against in our healthcare encounters. Okay, so first, in looking a little bit about what is trust, and we found that both among our own street medicine team and for our patients, it was really difficult to define trust. It was sort of like, you know when it's there and you know when it's not. And so I just summarized some of the things that people said about what does it mean to trust somebody else, or what does it mean to trust a doctor, social worker, or nurse. And the things they said were looking out for my best interest, the ability to have mutual honesty. So not just honesty from patient to clinician, but honesty from clinician to patient as well. Showing concern and compassion. There was some talk of intimacy, that it's an intimate thing to have trust between a healthcare clinician and a patient, particularly for people sleeping outside. And then I've tried to include a lot of quotes from our study because I thought they were particularly illuminating. This participant said, "Trust means helping me in my time of need. If I go to them and I need someone to talk to you that I can trust, who can hear me out through my pains and stuff." And I will say the word pain came up in so many conversations that the interviewer had with our friends who were sleeping outside. Okay, so what did we find? About 70% of people reported that the clinician seemed overall trustworthy, trusty, it's a new word. And that people who were seen more than once, 75% reported trusting the street medicine team. Some of them had sort of unqualified responses of like, I trust them with my lives, I trust them 100%, I completely trust them. And then other people had more sort of qualified statements of trust, such as, I trust them because I have to. And I trust them because people's like poor health could come at any time on the street, and I know I'm going to need somebody to be there for me. But it was sort of like there wasn't, I guess we needed to be, I think, more careful about people trusting us because they had to. So what were things that improved trust of the participant with any of the street medicine clinicians? And what were things that impeded trust? So the themes in this, and what I'm gonna say in the next couple of slides is like, it's not shocking. I think all people want this out of their healthcare. But communication was a big one, and it undergirded nearly every other element of trust that people brought up. Both in how people communicated verbally and how people communicated non-verbally. Reliability was another theme that came up. respect, being judgment-free, and having humanizing behavior. And then the quality of care that people got was also something that either promoted or detracted from a person's ability to trust us. So in thinking about reliability, there were kind of two components. One was dependability, and the other one was believability. So the dependability we found was both physically and emotional. People said that they could trust us to be there every week. We would go to the same places, the same encampments week after week. And they knew that if it was Monday, we would be at their camp and they could find us every Monday. And even if it rained, we would be there. It doesn't snow a lot in Atlanta, so that wasn't an issue. And then also kind of emotionally in terms of like, we wouldn't give up on them. We were there for them in their time of need. And I love this one. They just kept coming. They wouldn't give up. Sort of a relentlessness maybe. And then the believability, it was really about trust or honesty and transparency. So one of the things we encouraged with all of our street medicine team members and volunteers was that you really should make very few promises, but you have to come through on every single promise you make. And that was reflected in the interviews as well, that people wanted to know if we made them promises that we would keep those promises. And one of the participants said, if you're straight up with them and be real with them, they be real with you, and they'll help you with whatever you need or with any pain or whatever. This is what somebody said about their experience with healthcare providers. Not on the street medicine team. A lot of times being homeless, you don't be treated like a human being. You be treated just like you homeless. And this other participant wanted somebody, a healthcare worker, to behave in this way. I ain't scared to touch you. I ain't scared to talk to you. I ain't scared to sit beside you. Because we get so much of the disapproval when people come by and dislike the homeless people. Okay, so moving on to quality of care. High quality care was a strong facilitator of trust. Some of the descriptions of care that people received by healthcare workers who weren't part of the street medicine team were that they failed to detect medical or psychiatric conditions. They were misdiagnosed, and either they were given ineffective treatment and or they were not provided with informed consent about side effects and adverse reactions. I think it's really important for all of us to have bodily autonomy and be able to make decisions about our own healthcare. And one of the other things that people said is that they weren't invited to participate in their treatment. When talking about the street medicine team, patients said that we helped improve their overall health and well-being, and different people said sort of different things about what that meant. Some people had lower blood pressure. Another person said that we provided wound care that helped prevent gangrene. And then also people talked about the reduction of emotional suffering and the lessening of hallucinations. So some of the quotes: they saved my life. This was a person who had seen lots of other healthcare providers, and hepatitis C had gone undiagnosed, and we were able to diagnose him and help refer him in for treatment. To go through the pain and suffering that I be going through, hear in voices. They help and give me the medication that I need. And then they care about every part of you, from your feet, whatever. What we did find, though, is particularly in terms of people using substances on the street, and I would say that there were two people in particular who had asked the street medicine team for benzodiazepine, so things like Xanax, Klonopin, Valium, stuff like that. And the two participants who wanted those things felt like they were being stigmatized because of their history or current substance use, and that the doctor didn't trust them enough to sort of be told how much they should take and take it appropriately. And this really emphasized that trust had to be mutual, not just that our patients trust us, but that we trust our patients too. And then one man really kind of talked about how he thought if we knew how chronic he was, he used that word chronic, or if we knew that he was an ex-heroin junkie, or if we realized that he in his past had walked around dirty in the street with only a blanket covering him, that maybe we wouldn't have provided the same kind of care for him that we were anyway. Okay, and then this had, implications for treatment adherence. So people said that we saved their lives. People said people were more willing to go to the emergency room. And this is just what they said. They felt like they could trust other clinicians outside of the street medicine team better. They were more willing to take their medications on a regular basis or at all. And then 6 of the 20 whatever participants, I don't remember what I said, were engaging in some sort of in-clinic care subsequent to meeting with the street medicine team. Okay, so what did people want? This is kind of the ultimate conclusions of the study. Don't be afraid of me. Don't judge me. Don't tell me what to do. Don't rush me. Don't make promises you won't keep. And these are the things that we should be doing. Be humble, listen to me, tell me the truth, include me in my treatment, do what you say you will do, and treat me like a human being. This is my last slide, and this quote always gets me. They doing their best to get you right, to get you healed from the burning and hurting that you're going through with what's inside of you. They do good work to help you stay focused on the positive things other than the negative things. And my last is a shameless plug for the Street Medicine Symposium that's going to be in London in September. You can go to streetmedicine.org to find out more information about it. Thank you.
Thank you so much, Liz. So now we're going to have time for some questions.
Is this on? All right. Thank you. First, I want to say, Liz, Dr. Frye, whatever. Honestly, humbling and thank you for your vulnerability in your opening. I think so many times professionals, I've never heard a professional be human in a way that you were. And trauma-informed care and looking at the question, Simon, like you presented, and looking at that as a person that's critical of trauma-informed care, because sometimes trauma-informed care, because we don't know exactly how to do it, is done in ways that are trauma-inducing. And one thing that I've learned, and I try to bring as a person with lived experience and a person who's been traumatized by people in healthcare and people outside of healthcare, is how do we show up authentically, knowing that the trauma-informed is about ourselves as well as the person we're trying to support? Because I think we forget that, right? Like I think even in my own experience, I put my stuff away and I'm like, I can be objective, but really we can't fully be objective because we're human. So I guess my question, and answer it if you're open to answering it, and don't if you don't, because like there's probably not a lot of people that ask professionals questions about their own practices, but how do you show up authentically? How do you reflect on your own trauma when dealing with the trauma of others? If anybody wants to answer.
I will start. Yeah, I think that's such a key question. And thank you for bringing that up. How do I show up authentically? I don't know that I know that answer. I think that I do. And I think that a lot of it is maybe just sort of doing and saying the things that I said to you when I started. And I don't necessarily lead with that when I'm talking with my friends out on the street. But I like I've had a lot of conversations with other mental health professional colleagues, and there's this, I think, especially in psychiatry, that we're in some ways taught to be this like blank screen that people can sort of project upon in therapy. And that's like the opposite of what you want to be when you're doing street psychiatry or street medicine. That you have to be like, I show people pictures of my kids and I talk about my pets and I talk about my life and things like that in ways that I think will help me be more relatable, not to like consume the conversation. But I think just to be myself. And that's one of the things I really try to teach the medical students and residents who work with me, is that like, you're so busy learning how to be a doctor, because all of the people I'm training are doctors, that it's easy to forget to be yourself. And so I really try to work with them to remember, like, first you just want to be yourself, and then you might think about the things that you need to ask people or whatever to be their doctor. But if you're not yourself, you're never going to be their doctor.
So one of the things that's gifted to me in New Zealand, working with the Indigenous people there, is doing things slightly differently, because the traditional way in which people greet each other in Māoridom is they share whakapapa, which means your family history. So you work out who you know in common. So one of the ways that's changed my practice, certainly working with inner city health, is I tell people a bit about myself to begin with. So one of the things there's two things people usually notice about me first. One is that I'm a doctor, and all the projections that people have about what being a doctor means. And the second is I've got a funny accent. So one of the first things I often say is I've got a funny accent. I'm originally from the UK, worked in New Zealand, now I work in Canada. Maybe tell people a bit more about myself. I don't tell them about my mental health history or being treated for depression, because it's not all about me. But I do tell them, I feel like what I try and do is go one down. You know what I mean? And tell people a bit about me, so I'm a bit more vulnerable. That's how that for me is one of the ways in which you operationalize trauma-informed care, I think. Yeah.
I would say too, to kind of add to what Simon said, is that I similarly don't typically tell patients that I have depression, well-treated depression, but I use a lot of we language when I talk about mental health symptoms and mental health treatment and the experience of sort of like, we all feel this way when, and I think that's kind of my way of disclosing without disclosing.
I was wondering, this is a question, wondering if you've used any therapeutic alliance rating scales with folks you've seen, because that's predictive in psychotherapy, that's predictive in medication adherence. If you like the person who's providing you care, you're more likely to follow through. And there's some quick measures. I'm just wondering if either of you have considered that, or even for frontline staff who are working with people maybe more longitudinally.
Thought about it, haven't gone down that route, often because the relationship is in lots of bits. So you like encounter somebody for 2 or 3 minutes, and then next week you see them on the same street corner, you might see them a bit longer. So as opposed to in sort of typical psychotherapy setting where you're seeing people for like 40, 45 minutes continuously, and you get past that initial stage. But maybe you're right. Maybe we should be measuring it, but maybe not calling it therapeutic alliance. Maybe something like, do you want to hit your clinician scale?
Well, I think it's that important check-in. Like this is something I do now as a routine part of my practice, is always at the end, ask, what do you think went well? What could I do better? And that's been actually really important feedback to get for me as a clinician, to know when I'm screwing things up, or if I'm doing things well, but more importantly, it gives that person who I'm seeing the opportunity where you're removing that power differential.
Yeah, I went through a phase of doing that and I stopped it because I got a ceiling effect. Everybody said, "Oh, you're great, you're up," you know, but nobody dared say anything different at the end. I don't know. Maybe it's different.
No, I still get quite like constructive feedback, and I ask people to be genuine about it. But you can usually tell if somebody's irritated or not with you.
Similarly, I haven't used any sort of rating scales with that. I think sort of similar to what you do, a different master's in public health student worked with our team and found that if somebody other than the treating provider talked to the person, or that there was a lot of value if somebody on the team other than the treatment provider just did a follow-up question of like, did you get what you needed today, or are there other things that you felt like you needed that you didn't get? And so I think the importance of that kind of follow-up question was really helpful and illuminating. There are sort of two measures that I just personally like keep in my head. One is sort of what Simon alluded to, but for me, maybe slightly different, of sort of how long can somebody tolerate my presence? And I worked with some folks and I found that this was particularly true in terms of people experiencing psychotic symptoms, so particularly like hallucinations. Sort of an informal measure of how long would the person interact with me before they became so consumed in their inner world that they really weren't able to interact with me. And for some people, I think it was intentional. That one woman in particular I worked with, every time I mentioned HIV testing, it was the end of the conversation and she would engage in her own inner world. Similar, she also told me at one point, there were all these like Segway tours of people around Atlanta. You know what a Segway is? That like, okay, which I think are ridiculous anyway. But she told me that she would oftentimes begin to loudly engage with her hallucinations on the street so that people on those tours would avoid her. So anyway, my measurement of like, how long can this person stand to be with me? And then the other measurement that I think gets maybe a little bit at your question was sort of the likelihood of people referring one of their friends to me. I think that the biggest compliment on the street is when you get referrals from your own patients of like, I dragged my friend here to come see you because they need to tell you about this. And I just felt like that was the most, like it was truly an honor to have that happen.
I think like speaking as a nurse and also thinking about like the peer workers and the case managers out in the audience too, like sometimes the interesting part of that evaluation is like how much engagement has happened up to that point to get like as somebody who works very closely with Simon, there is like, you know, sometimes months of nurses and peer workers meeting with people to get them to finally meet with a psychiatrist. And so afterwards, if as a nurse or a peer worker, or if we feel like that went well, in some ways, like Simon has been open to like, yeah, that was a good engagement. Because like, it's really awful also as a nurse or a peer worker if you are like, have done all that work and then you're like, oh, like, fuck, that person was an asshole. Like, so I think, because we see that sometimes when we go out into the world with our clients. So yeah, so that's also just some feedback as well. Anybody else got questions?
This is just for the whole panel or anyone else for that matter. I'm a nurse practitioner and of course an expectation is that we come up with a treatment plan, and I'm wondering how you incorporate strengths into that, or if you do. Like, for example, you know, you're going to take this medication for dissociations and you're going to take this for sleep. Can, other than me writing in the note, shows incredible resilience or something like that, is there a way to incorporate the strengths into an actual plan? Or yeah, that's it. And thank you.
Thanks, Christy. Long time no see. Yeah. Well, clearly writing it with the person helps. You know, that's assuming people are that they're literate enough to do that. Always got to check that in the first place. One of the things I've learned so far from doing the qualitative study about trauma-informed care is something I used to do a bit, and I've heard it done a lot, done by other people, is people say a strength is being a survivor. And when we do the qualitative interviews, nobody likes that. They say it somehow often ignores people's experience or doesn't do it, doesn't justify the awfulness of what's happened to people often. So I'm tending to try other ways to incorporate strengths rather than necessarily thinking about people as survivors. I mean, it's a qualitative study, so I don't know how common this view is, but it's something that's come across from more than one interview we've done when we've talked about strengths. Because I'll bring it up because yeah, it's one of those unexpected things. I mean, some of it goes into the motivational interviewing things. You know, like why do you want to change? I mean, is it because you want to be a good dad to the kid you haven't seen for 6 months and you want to, you know, make them proud of you? Talking about those sort of strengths. I don't know. Other people may have better ideas than me.
I mean, I will say I hate treatment plans. It's not because I hate planning treatment. I do that all the time. I hate the formality of being required to write a treatment plan when no one else in medicine is required to do that. That being said, I think probably the way I ask about it is more like, tell me what you want out of your life. Like, what are your hopes and dreams and goals? And I think we will sort of use that to inform what we understand about their strengths. But that being said, I think it's probably helpful and important to ask people more directly and saying like, what or who do you rely on to get you through, and what do you like about yourself?
I had a question for Simon. With your research, how much is the pay? What are the age restrictions, and how is pay paid out?
For the study that I mentioned, it's $25 for about 30 minutes, and it's paid out with a gift card, which you can use anywhere. The REB says we can't hand out cash, and checks you can't. You need a bank account for a check, so we give people gift cards they can redeem anywhere.
Age restrictions?
18 and above, because I'm an adult psychiatrist.
Thank you.
I'm not allowed to talk to children.
Is that how it works?
I couldn't possibly comment.
I was in the study for one of the studies you did for the trauma-informed care. I liked it. It's interesting. I like because what I see is it's like a one step in having experienced psychiatry from the other side of things. So like, I don't know, it's like lived experience, but then it's like you can talk about it as being a marginalized person, then you can talk about it as something else and everything like that. But I'm like one person going through the same kind of situation. So I was just wondering, like, it seems like there's a lot of, I was just talking about it outside with Bobby, but like a lot of stuff gets worked into like with the research and like a clinical approach into like isolating different variables and stuff, when actually in our experiences, these things are integrated. So then it comes back around to trying to integrate it later. So I know like in your models of like building from safety to other things, like, and eventually getting to like cultural factors and stuff like that, that people who are the most marginalized, who are dealing with the most like pain and suffering in our culture, actually are at the intersections of these things. So it feels like what I'm wondering is like what the benefits could be if you want to talk about like taking a more critical approach, whether it's like starting out with anti-racism and like a decolonizing like lens and stuff, because when you start then at the end asking like addendum questions like how did I do as a clinician and stuff, when you're not recognizing like from a feminism sort of like something that's been understood for a while now, that like that, or then just what we're talking about here about the power differentials and stuff that you're bringing to the play, to only ask about them at the end. It seems like, can we shine more visibility on people's experiences of clinicians, like of like measuring the factors about like the power dynamics that like clinicians are taking into place, like training around like examining not just your biases, but like these internalized structures within you so that you're not presenting in the same sort of way, even if you seem to come from like a place of privilege and stuff. And the other big, so yeah, I just want to add the last two things about like, I see like a cyclical element of it where the cultural elements and stuff, the things that we have in the end up coming back to our sense of safety. And if you look at people who just take a more critical approach to like trauma recovery care and stuff, our sense of safety is not absolute in our society. So trauma-informed care is literally like trauma is supposed to be exceptional. It's supposed to have happened in the past. We're supposed to ground ourselves in the present, stuff like that, move on to a safe society. For a lot of us, we live in a discriminatory, systemically so society, so it's not safe. So what I've learned a lot in my own recovery and stuff like that, just to keep it all short, is like working in gradations. That's why I like harm reduction so much. Getting away from the black and white, like clinician versus like patients and stuff like that. Getting more into like this gray area. Yeah, and then just like a cyclical approach. I don't know if you ever think about these things, like where you put the visibility, how to like operationalize things about like clinicians and that kind of thing before entering a space.
Yes.
Sweet.
Yeah, we do think about it a lot. Nicole Dunn, who is still here, is she still here? Yeah, oh, there she is. I mean, to talk a bit about this yesterday, and she articulated it far better than I could. About power dynamics. One of the difficulties is, I don't know, I'm sort of thinking on my feet here. One of the difficulties is operationalizing that to make what you actually do. The other difficulty is, of course, that people often come to me because they bad stuff is happening to them in the here and now, and they want often, you know, they want often relief from symptoms. And I feel compelled to do something about that. And also, I think you're right about the power stuff, and I don't think we address that enough. I think if Deji was here again today, he would be far more articulate about than me about this. He's somebody else with long COVID who was presenting yesterday. It's part of the qualifications we're presenting here. So, yeah. So, and I think the mistake is to make the assumption is to try and strive for no power difference, because there is difference in power. But I think the way to go is to be transparent about that. You know, I have the power to make people go into hospital, and that's something that the law gives me the ability to do, and I think rightly so sometimes. But we can't pretend that doesn't exist.
The only other thing I would add is there's actually a scholar that I worked with briefly at Western who's actually doing a project about power dynamics for people who are unhoused when it comes to food security, interactions in shelters, interactions with social care providers. So I can provide you, she's having a hard time getting it through ethics, but I can give you that information if you're interested.
Hello. Hi, my name is Bronwyn. I'm not a doctor or a frontline worker. I'm just a regular Joe with lived experience. I don't necessarily have a question, but I feel like we could have dove deeper into what is trauma in the definition. So I kind of wrote it down here. Trauma is shaking violently at the thought of your abuser finding out where you and your children have fled to. Trauma is not being able to engage in physical touch because just the thought of it brings you back to a terrible time and place in your life. Trauma is laying in your tent at night, afraid to fall asleep because you know upon waking, your life's possessions will be gone. Trauma is not being able to leave a relationship because the fear of pain is all you know. Trauma is looking crazy on the bus because you break down in tears at the thought of a past event. Trauma is what led myself to drugs and alcohol as a way to cope with my past. Trauma is needing to be strong to survive when all you wanted was to be safe. And I just think it's important that all of us know in dealing with trauma, these are just some of the things that we deal with. So thank you.
Thank you, Bronwyn, for that gift. Very, very articulate. You should write more. Do you write more? Okay, cool. Have you read? Has anyone here read the Stephanie Fu book? What's it called? Do you know what it's called? It's something like My Bones Hold the Memories or something like that.
I can't remember the title, but yeah.
No, it's not. It's not My Body Keeps the Score. It's sorry. Oh, what my bones know, which is a very articulate description of a journey of, well, not recovery from PTSD, but managing PTSD, complex PTSD better. Yeah, similar level of articulateness. Very triggering for a lot of people who've had difficult time with their parents as well.
Oh yeah. I just was going to make a little comment just about just when we're talking about approaches to trauma care or trauma-informed care, just being there and kind of also always assessing in the approach in the moment. And I think and I think that speaks to the importance of having more clinicians out on the street, more workers, more peer support, everyone, so that when the signals are there from the individual, the cry for help and having somebody recognize that and respond in that moment, I think those are those magic times that, you need to hone in on. You can have all the lived experience, you can have all the credentials in the world, but if you can't pick up on those signals, then, you're missing so many opportunities to help people. I just wanted to bring that up.
I will say, I think in thinking about the power differential too, one of the things that came up in the qualitative study that I did was the importance of sitting, particularly in doing street-based work. I think you get taught in med school that your patients know that you're spending, or the patients feel like you're spending more time with them if they sit, or if you sit. But sitting on the street, I think has a different, it's a different thing. And so oftentimes I will invite the person that I'm talking to see if they want to sit with me and talk. Because when you sit on the sidewalk or on a curb or wherever, you put yourself more into the experience of the person who sleeps there. The other thing that I really love is in the logo of the Street Medicine Institute. I don't know how many of you all saw this on the slide, but the person with the backpack, the street medicine worker, was the person that was kneeling in front of the person they were caring for in that image. And I really like that idea of kneeling in front of someone that you're working with, not just the sort of physically putting yourself in a lower position, but sort of emotionally putting yourself as the learner, I think is a really, and telling people that too, I think is really important. I don't have any sort of disillusions that fixes the problem. But I think it's an effort that I make to help improve the problem.
So on that note, we're going to end for lunch. So we have kind of an hour to help yourselves to some food and take a walk. And then we'll have everyone back for 1 o'clock.